Let's explore how spirituality impacts healthcare, connecting both care providers and patients alike.
To present to you today our paper on the ethics of cultural competence training with references to faith practices and spirituality. As I was developing this paper for this conference, I realized that I had a lot of interests in common with her and the particular population that she works with. We're two very different groups. I work mostly with undergraduate college students. She works with a different situation than I do. And we realized a lot of the interests and awareness that we had applied to both populations despite their significant difference. And you can hear that in what I present to you in this paper today. The concept of cultural competence in medical care and behavioral health care is expanding exponentially to include awareness and skills not only relating to traditionally framed cultural differences, but also to such things as gender complex diversity, workplace violence, HR compliance, use of inclusive language, proper use of AI, encouragement towards second language learning, and even more than that, the concept is truly expanding and is taking overtly subjective dimensions as well when it encourages people to examine their perceptions and truths and values alongside the expected measurements for it. It's really becoming linked to such matters even as social justice, with a view to promoting equitable access to medical care and behavioral health care as well. Add to that the individualization of subcultures and cultures, and the concept's proportions have become behemoth. Undoubtedly, cultural competence is an essential component of both effective medical care and behavioral health. And those are our two different assignments here. I tend to work a lot with nursing students online, teaching coursework in competence with regard to ethics. And she with this very different population. And we both are taking a look, therefore, together at, for example, acervic standards from my field, but also a number of other standards from both fields together. With these factors in mind, our paper argues 3 points. A, that spirituality, faith practices, and religion are determinants of physical and mental health outcomes. B, that there are ethical and legal imperatives for respecting and becoming competent in spiritual and religious and faith practices. And C, that clinician-patient relationships, rapport, and communication enhancement can be based on these competencies. This paper is far too long to present in the amount of time that we have today, but I want to give you some highlights from it. And then, of course, in the question-answer time, we can explore any of the details that you're wondering about that I didn't get to include in the presentation. Based on Snowden, Leggett, and Taylor's systematic review, clinical supervision improves the effectiveness of care and patient experience by fostering a reflective practice, skill, and development, and professional growth. So inasmuch as supervision is a proven driver of better patient outcomes, it follows that the content of supervision and training should include the full spectrum of competencies necessary for high-quality patient-centered care, and this includes cultural competencies, of course, in this area we're exploring, namely spirituality, faith practices, and religion. We're in a changing trend, and this changing trend is unmistakable. Fewer than half of Americans today, and we are indeed centered on what is the American and North American experience in particular, fewer than half of Americans report attending church services of any kind regularly, with millennials, those younger are reporting that even less so. Now, on the other hand, as church-based involvement drops, or any kind of worship setting involvement drops, 2 out of 5 Americans report that they are becoming, quote, more spiritual. That's according to a 2024 Gallup survey. So these and related statistics, which are in our paper, though I'm not representing all of them in the presentation today, show that religion, rather than disappearing, is morphing into increasingly individualized experiences of spirituality. That's what we're really centering around today, and we draw from much material in the APA, the AMA, ACERVIC, and other standards. In our paper, even though I'm not representing all of it right now. Over the past several decades, Western societies have experienced a marked paradigm shift in how individuals conceptualize and engage with the sacred, moving from dominant frameworks of institutionally related religiosity towards more personalized, subjective, and differentiated understandings of spirituality, faith practices, and religion. One might say a lot of this is wound up with privatization, individualization. The two go hand in hand, and very much forwarded by technology that allows a high degree of privatization as well. So we're interested in that. We're interested in the fact that religion, while salient, is now more narrowly understood as an organized system of beliefs, moral codes, and community worship, but often mediated by an institutional authority, whereas we're seeing a perceptual shift away from that. It's still there, but it's away from that increasingly towards secularization and so forth. They're reflective in many ways of cultural pluralism. It means that assumptions that counselors and religious authorities and medical care workers may come with based on appearance or cultural background or demographic indicators risk misrepresenting a patient's values and needs. And that's the direction that we're centering on in this paper. The contemporary distinctions between spirituality, faith practices, and religion have significant implication for physical and mental health outcomes. Decades of research show that these domains together serve as important, if you will, protective factors, in some cases, although sources of distress, helping to, for example, disease progression, treatment, adherence, and recovery. Spirituality, understood as the search for meaning, purpose, and connectedness, has often been associated positively with reduced stress and a greater resilience and improved coping and chronic illness experiences. Faith practices such as prayer, meditation, fasting, and community worship have been linked to physiological benefits such as lower blood pressure, enhanced immune function, and improved pain tolerance. Likewise, religion, when experienced as supportive and community-oriented, can provide a sense of belonging, moral guidance, tangible resources that enhance the psychological well-being and physical health outcomes. And we are specific in our paper on the studies that we're citing in support of this. So, building upon the recognition that spirituality, faith practices, and religion are integral determinants of health, it becomes evidence that healthcare providers have both an ethical but also a legal responsibility to address, as much as the patient or clinical person desires, the domains with respect to competence and respect. Ethical imperatives are grounded in the professional codes that we are citing at various points in our paper. So in both mental health and medical contexts, this competence extends beyond tolerance to a proactive engagement, which includes an accurate assessment, respectful dialogue, and integration of spiritual or faith-based resources when appropriate and when desired by the patient. So the competencies required to address spirituality, religion, and faith practices in healthcare not only fulfill ethical and legal imperatives, but they also serve as a foundation for strengthening clinician-patient relationships. Cultural humility and spiritual competence foster, which is essential for effective therapeutic alliances. And when clinicians demonstrate a genuine respect for the patient's belief systems and integrate these values into care planning, patients are more likely to perceive their providers as empathetic and understanding and aligned, at least in some degree, with their own personal goals and values. Such rapport is associated with improved patient satisfaction, higher adherence to a treatment regimen, along with a greater willingness to improve patient well-being and thus enhance both clinical accuracy and positive patient outcomes. This effective root in these competencies also will help address potential barriers that might arise at a number of points. So incorporating these competencies into everyday clinical practice has a cumulative effect, reinforcing a care environment that values the whole person, mind, body, and spirit. And as trust and rapport deepen, patients are more likely to engage in open, honest communication, even when discussing challenging topics such as, prognosis, end-of-life care, if appropriate, or ethically complex interventions of some kind. And by grounding a relationship-building tendency in spiritual and religious competencies, the clinicians can navigate these sensitive discussions with a greater cultural awareness. So structured cultural competency courses represent an essential pedagogical